This is Dr. Sargisian, and today we'll talk about asthma and the genetic influences on asthma and genetics origins of this disease. So, topics of our genetic series are listed here, and today's discussions falls under the analyzing the relationship between genetics and this disorder and facilitating the integration of genetics and genomics in pediatrics primary care, including assessment and screening. Asthma belongs to complex disorders. These are disorders that require both genetic and environmental component. So if someone has genetic makeup for the disease, it doesn't necessarily mean that this person will develop disease. To develop the disease, environmental input is necessary, and when environmental triggers are present and it's the right time or the wrong time in the individual's life, then person may develop the disorder. The diseases discussed here in this lecture series are diabetes type 1, diabetes mellitus type 1, and asthma, and both of them need the emergence of the triggers in childhood in order to occur. So asthma is a chronic inflammatory disease of the airways. It's usually characterized by intermittent periods of obstruction of the airway or airflow obstruction. Fortunately, this obstruction is reversible, and uh, patient may have exacerbations which commonly uh, named as asthma attacks. So there are three mechanisms that contribute to asthma. It's constriction of smooth muscles in small airways, inflammation and swelling of mucous membranes in the airways, and of course, excessive mucus production and clogging the airways. The most common type of asthma is atopic, which is a hypersensitivity reaction, basically an allergic response. And in atopic asthma, the release of immunoglobulin E will occur. So, in this type of asthma, the all of these three mechanisms described above may occur, or one or two of them, but usually, obviously, one of them at least present, but at least one is present, but all three may occur. It begins in childhood and it has familial character, so there are other family members that have this. Uh, in the past, it's interesting that some people thought that the children will mimic family members' behavior, and that some kind of supratentorial learned behavior, uh, and children are doing this to get attention. So, of course, that's not the case, and asthma is very specific, and it has been shown that there is a special chemical changes and physiological changes occur, and it's definitely can be diagnosed and fortunately treated. So asthma can have mild to moderate character in majority of population, and medication can control it. And also another important point here, the avoidance of environmental triggers, which will obviously reduce the number of asthma attacks. Familiar predisposition for asthma exists, as I mentioned previously. There are uh, around 100 genetic variations that are known to uh, to be associated with asthma, and some of these genetic variations are stronger than the others, but again, asthma uh, can be caused by a variety different genetic variations. So genetic variations can affect one or the other ethnic groups, and depending on what the genetic makeup is, the again the asthma may affect this or the other ethnic group. But again, doesn't matter really what's the genetic makeup. It's again the presentation is essentially the same. So asthma can be associated with single nucleotide polymorphism, and one of these genes is DENND1B gene that produces a protein which is active in secretion of the inflammatory protein tumor necrosis factor, or as you know, TNF. And this protein active especially in macrophages and mast cell. So this leads to uh, development of immune responses, and this is part of non-specific inflammatory response provided by these cells in acquired immunity. So this will happen again in susceptible people if they are exposed to a trigger, and trigger usually in this situation is an allergen. Okay. Some of these responses are mediated by IgE, and as you already know, IgE will be elevated with asthma in these people, and also will be number of other inflammatory markers present, or inflammatory uh, substances present, such as histamine, bradykinin, and TNF will be elevated, of course, and interleukin 13. So another gene is GSDMB, that it's tied to a production of protein that is important in epithelial cell function. And the cells are everywhere, obviously, but they are also in airways. So responsiveness of airway cell may increase if this gene is mutated. And by responsiveness, I mean that airway will be very responsive and active if some type of irritant is introduced into airway. Another gene, ORMDL3, produces protein that regulates calcium level in endoplasmic reticulum of inflammatory and epithelial cells, and changes in this protein again associated with inflammation. So to summarize this, the major issues in asthma genetically are an increase in responsiveness of airway when the environmental irritant is introduced, and the other option or the other component is the increased inflammation and presence of immunoglobulin E, or IgE. So, and this is a just small overview of genetic makeup of asthma. So environment, as I've mentioned previously, has to be present, or environmental factors should affect a person who is predisposed to asthma, for asthma to develop. So all people have airways that may respond with bronchoconstriction and inflammation if an irritant is introduced. The example is someone is trying to learn how to smoke and they will have major cough and inflammation first time, but then they are getting used to it. So presence of irritants, or like in this situation, cigarette smoke, stimulates the nerve fibers, and at that point, the airway responds with contractility. So, environmental irritants include, like I said, smoke, cold air, dry air, airborne particles, again, like smoke or other environmental pollutant, microorganism, even aspirin, and finally the exercise that can increase the respiratory rate. So signs and symptoms of asthma. The changes in airway tissue will lead to narrowing of the airway, and especially in, of course, people who have genetic makeup for this, and will result in airway hyperresponsiveness. So again, environmental trigger is needed for this to start. Inflammatory and immune responses also tied to an allergen. So this will lead to different tissue changes. The allergens obviously need to be inhaled, and in some cases they can enter body through different routes, but inhalation is the most common one in asthma, and the allergen will bind to IgE and trigger the inflammatory response. So when this happens, mast cells and basophils will start triggering the inflammation of mucous membrane, and mucous membranes will start producing big amounts or large amounts of mucus. At the same time, the inflammatory substances will be produced. These substances will attract eosinophils, also macrophages and basophils. You probably remember old saying about eosinophils. They are present in worms, wheezes, and weird diseases. So by wheezes in this situation, or in that saying, we know that asthma was mentioned. So with worm, wheezes, and weird diseases, if you have elevation of eosinophil, that's probably related to asthma, intestinal worms, or some rare disorders. So, okay, again, if allergen introduced, it also will lead to some degree of bronchoconstriction because the smooth muscle is triggered. So again, it will lead to airway obstruction, and externally, which adds to internal airway obstruction from mucus overproduction. Children with atopic asthma have no symptoms between the attacks, but they may present with allergic type issues with allergies. So they will have rhinitis, allergic rhinitis, skin rashes, or even itching. And asthma attack will be manifested as difficulty breathing and chest tightening and coughing, wheezing, and increased mucus production. Okay, so like I said, worms, wheezes, and weird diseases. So wheezing will be pretty loud and audible, and in this situation, as the attack worsens, and the wheezing not only heard on exhalation, I'm sorry, but also when the child inhales. So, but initially it's only exhalation. So respiratory cycle is longer and requires bigger effort. And the child even may use accessory muscles to breathe. So you may notice that there are muscle retractions at the sternum, and even suprasternal notch will be visible. Okay, so patient, in this case, pediatric patient, may have difficulty or inability to speak, and even may become cyanotic. So pulse ox at this point will show hypoxia, and saturation levels will drop below 90. So peak flow meters will be at child uh, will be below the child's usual value, and of course PaO2 will decrease during asthma attack, and PaCO2, carbon dioxide levels, will increase. So if you do lab work at this time, you will see the elevated eosinophil count and elevated IgE levels. So basically E with E, eosinophils and IgE. So the treatment includes several pharmacological options, and but it can be divided into two uh, types of medications: maintenance and rescue or reliever medications, which like reliever or rescue medications will lead to relief of symptoms within few minutes when patient is having asthma attack or exacerbation. So also you may give the reliever medication if patient engages in exercise. So if patient has history of exercise-induced asthma. And also the controller medications, which are usually given for maintenance or maintenance medications. So if patient on good controller medication or good controller medication regimen, the severity and most importantly frequency of asthma attacks will decline. So the most used classes of asthma medications are beta-2 adrenergic agonists, and corticosteroids and leukotriene modifiers, and usually in this class it's montelukast. You may utilize stepwise approach for pharmacotherapy in patient with asthma, and so in this stepwise approach you may start the treatment that is most appropriate and matches the severity of asthma when the disease was first diagnosed. And then if patient doesn't have control within 3 months, the step up is recommended. So there are different guidelines, not to go into details, for adolescents, children, and adults. So basically the guidelines slightly change depending on the patient's age.